Today, we will be demonstrating a very common and important procedure for patients with liver disease, paracentesis. We have no financial disclosures relating to the topics being discussed in this presentation. Paracentesis are performed in adults for a number of reasons. They can be broadly divided into two types: diagnostic paracentesis and therapeutic paracentesis. Diagnostic paracentesis are procedures which are performed in which small volumes of fluid are retrieved for diagnostic purposes. And therapeutic paracentesis are performed to remove large volumes of fluid for symptom relief. Diagnostic paracentesis should be performed in all patients with new onset ascites of unclear origin. The main reason for doing this is to differentiate if a patient has ascites due to portal hypertension or something else. Portal hypertension can result from cirrhosis of the liver, and this is the most common reason for ascites. However, it is important to note that there are other causes of ascites which are not related to portal hypertension, and these include such things as peritoneal carcinomatosis, infections such as tuberculosis, nephrotic syndrome, and pancreatitis. In addition to using paracentesis to differentiate the cause of ascites, a diagnostic paracentesis should be obtained when there is a question of spontaneous bacterial peritonitis, or SBP. SBP is a life-threatening problem which is common in patients with ascites from cirrhosis, and it can occur in the presence of classic clinical findings such as fevers, chills, leukocytosis, abdominal pain, and septic shock. However, it should be noted that it can also be present even in the absence of these traditional findings. Other clinical findings may be subtle, including worsening ascites, worsening hepatic encephalopathy, worsening renal insufficiency, acidosis, and gastrointestinal bleeding. Or there may be no symptoms whatsoever, and many experts recommend that all patients with cirrhosis ascites who are hospitalized should undergo a surveillance paracentesis at the time of admission due to the presence of occult SBP in these patients. For therapeutic paracentesis, large volumes of ascites can be removed due to refractory ascites or other causes such as malignant ascites and occasionally cardiac ascites. It is important to note that large volume paracentesis is not the first-line treatment for ascites. Rather, sodium restriction and diuretic use are the first-line treatment, and large volume paracentesis should only be reserved for patients who are refractory to these standard treatments. The reason for this is the increased risk of infection, malnutrition, and renal failure with repeated large volume paracentesis. In the short term, the patient may feel like they have benefit, but they are very short-lived in the span of about a week or more, and it has great risk to the patient in the long term. There are very few contraindications to paracentesis other than true disseminated intravascular coagulation, DIC, where paracentesis should be avoided. Patients with cirrhosis will often have underlying coagulopathy and thrombocytopenia. These are not contraindications for paracentesis. The overall risk of bleeding is low, with a risk of less than 0.2%, and FFP and platelet transfusions are not routinely recommended in these patients. There is a slight increase in bleeding risk in patients with increased creatinine, and thus extended post-procedure monitoring may be recommended in this circumstance. One should also proceed with caution in pregnant women, patients with organomegaly, bowel obstruction, intra-abdominal adhesions, or distended bladder. These are situations where ultrasound guidance is clearly recommended. In regards to the equipment required for paracentesis, ultrasound equipment is recommended if available, particularly if the fluid is not visibly present on clinical exam. There are a variety of available pre-packaged paracentesis kit, and one should become familiar for the one that is available to them. In addition to the catheter over needle device that is usually present in the kit, we will also need sterile gloves and cleaning material. Sterile gowns are not mandatory but may be useful. We should also have available the anesthetic to be used. This is usually 1 to 2% lidocaine. Diagnostic tubes are needed for analyzing the fluid and should also be prepared. At the very least, aspirated fluid should be sent for cell count to rule out SBP. This is usually placed in a purple top. Other diagnostic tubes that may be needed include blood culture bottles, which are needed for culture and sensitivity. It should be noted that the bacterial count in SBP is quite low, and if you do not place the fluid obtained in blood culture bottles, your likelihood of having a positive test will be significantly decreased. In addition, you may need tubes for albumin, protein, amylase, gram stain, and cytology. Please note, we do not classify the ascites fluid as transidate or exudate, similar to thoracentesis fluid, as these are not useful markers, so pH and LDH measurements are not needed. Note that all diagnostic fluid should be aspirated using the syringe. It is not advised to obtain the fluid after it has been suctioned into a large volume container for diagnostic purposes, as these samples will be contaminated. Rather, you should connect the tubing to the large volume container or wall suction after you've completed your retrieval of the diagnostic fluid. Prior to initiating the procedure, you will need informed consent, advising the patient of the risk, including bleeding, abdominal wall hematoma, infection, injury to intra-abdominal organs, post-procedural hypotension, and persistent leak. The patient should then be placed in a supine position with the head slightly elevated. You next localize the ascites using either a clinical exam for shifting dullness or, if possible, using ultrasound guidance. The site for paracentesis include either midline, 2 centimeters below the umbilicus, or right or left lower quadrant, 2 to 4 centimeters medial, and cephalad to the anterior superior iliac spine. You should take care to avoid scars and hernias when you choose your site. The area is then marked and sterilely prepped. Site selection is very important. The midline approach is often preferred because it occurs in the linea alba, which is devoid of blood vessels. However, it is important to have your patient void their bladder, as the urinary bladder is a concern in this location. For obese patients, lateral approach is sometimes helpful as the abdominal wall is thinner, and thus it may be easier to localize the fluid. However, you must be very careful that your position is low enough to avoid the liver and spleen, and you must also be sure that your location is lateral to the rectus muscle in order to avoid the epigastric arteries. After you have marked your area, be sure to use sterile gloves and face shield. Cleanse the area carefully with an antiseptic solution, followed by sterile drape. Using a 22 to 25 gauge needle, anesthetize the skin by creating a wheal with 1 to 2% lidocaine in the skin. Once you have anesthetized the skin, you can place the paracentesis needle directly into the site along the anticipated trajectory of the paracentesis needle and slowly inject and pull back on the plunger until you have reached the fluid. At this point, you can come back a little and try to anesthetize the peritoneum with 3 to 5% lidocaine. A total of 5 to 10% of lidocaine is usually needed for the entire process. Once you have numbed the area, you can insert the needle. For initial insertion, attach a 5 to 10 cc syringe to the catheter needle device to obtain fluid for analysis. When you insert your catheter needle, it is important to use one of two techniques, either the angular insertion method or the Z-track method. The angular insertion method involves use of a 45-degree angle to skin to insert your needle. The Z-track involves pulling down the skin down 2 centimeters prior to inserting your needle in a perpendicular fashion. After you are done with the procedure, the skin will retract over the needle over the tract you have made. Be sure, if you are using this method, that the skin is adequately anesthetized at the site of insertion. It is also important to use one of these two techniques in order to avoid the burdensome complication of continued leakage of peritoneal fluid from the site. Hold the syringe with your dominant hand and shaft of the needle device with your non-dominant hand. Advance in small increments of 2 to 3 millimeters, intermittently pulling back on the plunger to assess for fluid. You may feel a sudden loss of resistance as you enter the peritoneal cavity, at which point your needle fills with ascites fluid. Immediately stop advancing the needle and thread the catheter over the needle and withdraw the needle. If more diagnostic fluid is needed in your original syringe, attach a larger syringe to obtain more fluid. If large volume paracentesis is planned, attach the catheter to the high volume connection tubing, which is attached either to a sterile vacuum container or wall suction. For analysis of the fluid, we would recommend that all procedures being performed for patients with cirrhosis be sent for cell count, given the high risk and devastating consequence of undiagnosed SBP. For SBP, the diagnosis is made with an absolute neutrophil count of greater than 250 in the fluid. For new onset ascites, a serum ascites albumin gradient is recommended, or SAG. This is calculated by subtracting the ascites albumin from the serum albumin levels. A SAG of greater than or equal to 1.1 support that the cause of ascites is due to portal hypertension, which is most commonly due to cirrhosis, but can also be due to cardiac failure, portal vein thrombosis, but Chiari or extensive liver metastasis. If, however, the SAG is less than 1.1, this would support another cause of ascites, including peritoneal carcinomatosis, tuberculosis, peritonitis, pancreatic ascites, biliary ascites, nephrotic syndrome, or serositis. For large volume paracentesis, the catheter is attached to a suction device which can either be a vacuum bottle or a suction which is applied to the wall suction. With the wall suction, start with continuous low suction and only titrate upward as needed. During and post-procedure, the patient should be observed and monitored for vital signs. The cell count should be available before the patient is discharged from the unit, as it would not be advisable to send patients home without being sure that they do not have SBP. For patients with large volume paracentesis, particularly in patients with cirrhosis, there is significant concern for large volume shifts which may predispose patients to hepatorenal syndrome and death. Because of this, we routinely give cirrhotic patients albumin if greater than 4 liters of fluid are taken out, using 12.5 grams per liter removed after 5 liters. This practice is somewhat controversial as albumin is costly and there is no clear evidence to support the use of albumin in large volume paracentesis. However, we find that in our patient population, concerns for hepatorenal syndrome are quite high, and since we are very prudent in our use of therapeutic paracentesis, we feel that the risk of albumin is far outweighed by the benefits. Thank you for your attention.